As I said before, welcome everybody to our seminar on self-injury awareness. I am Dr. Andres Fonseca. I'm a consultant psychiatrist. I'm one of the founders of Thrive, and I'm the CEO currently. And Adam, do you want to sort of say who you are as well?
Yes, good morning, everyone. Thank you for joining us. I'm Adam Huxley. I'm a consultant clinical forensic psychologist and the other co-founder of Thrive. Andreas and I have worked together for a long time, and we've had the experience of managing people who present with these sorts of difficulties. So
Oh, Adam, you're breaking up, unfortunately.
we're trying to bring that into the
Adam, you're breaking up. I don't know if there's anything that you can do to.
Okay, let me try and join.
I mean, we can hear you, but you broke up quite badly during your intro.
Okay, let me try another machine. 1
I
second.
mean, it's okay now. I mean, I think so. What Adam was saying is that Adam and I have worked together for a long time, even as clinicians, and we've had many individuals that we've looked after presenting with this particular condition. So what we're going to do is, so Adam first is going to sort of give you an overall sort of understanding of the topic and what we know about it, and just a basic outline. And then we'll discuss one particular vignette, which is a presentation of this condition, a real clinical case. And then we'll open up for questions. But as I said, any questions that you have along the way, please feel free to sort of submit them through the Q&A box. Adam, do you want to go ahead and start?
Yes, I hope my internet connection works okay. If it doesn't, I'm sure Andreas will drop in. But yeah, I guess we wanted to just start off by acknowledging that this is a pretty sensitive topic, and just to sort of be mindful when we're talking about some of the things that we'll run through today, particularly the vignettes. And if you could do the same as well, please just sort of check how you're feeling and make sure that it feels okay for you. It is something that elicits a strong response in society and for family members and for people generally. So unfortunately, we still see that there's quite a bit of stigma attached to people who self-injure or self-harm. So it's just really to sort of start off acknowledging that, really. But yeah, I guess, just to try and introduce some of the terms that we might use today, and we'll probably use them interchangeably. And these are terms that might help us understand the motivations behind why somebody might harm themselves. So we typically think of terms like self-harm or even self-injurious behavior, and then non-suicidal self-injury. So those are all terms that we might use to try and describe a behavior that ultimately leads to some form of harm for the person themselves. But the interesting thing here is there's a bit of a contradiction in terms, really, because we've evolved with the idea of keeping ourselves safe. We wouldn't have made it this far as a species if we hadn't found a way to keep ourselves safe from threats. And those might be threats from external things, but also the threats that we might cause to ourselves through things like being reckless. So we have this instinct to survive. So it's then quite hard to understand why so many people harm themselves each year, either through, reasons to try and self-soothe, as we'll hear a little bit about later, or to try and express themselves in a different way other than using words. So the other thing to think about is, if we're using these terms like self-harm and self-injury, is there a difference between the two? And I think when we're trying to sort of think of differences or similarities, we might think of motivation. So sometimes we might think of self-harm as maybe an intentional act. So if we look at some of the descriptions of self-harm in the literature, we see that it refers to any act of self-poisoning or self-injury carried out by the person, irrespective of their motivation. And then if we look at non-suicidal self-injury, so self-injury that doesn't end in the person's death, we see that it could be a direct, deliberate destruction of our own body tissue. So we usually think of actions that relate to things like hitting or punching an object to inflict an injury to ourselves. Some of you obviously might be aware of people who may cut or scratch their skin quite extremely, or maybe even pick at a wound, or maybe even burn their own skin. So these are sort of examples of when somebody might deliberately harm themselves through the destruction of their own body tissue. But we can also extend that to think of other behaviors which might cause us harm, but the harm might be a byproduct of something else. So if we think of things like restricting our eating, that may have a harmful effect to us in terms of our physical well-being or even our psychological well-being. Or if we're using substances, one of the effects of using substances might be that we injure ourselves, or even unsafe sexual practices. So sometimes the self-harm might be motivated directly to try and injure ourselves, but it also might be the case that we engage in certain practices that end up causing us some harm. So then it might also be helpful to think about what factors are associated with self-injury. And that's a really large topic of debate, and one that we don't really have time to go into as much detail as perhaps it merits. But we know that there are a number of mental health conditions that we would associate with self-harm. And as we'll see a bit later on, it doesn't have to be the case that there's a pre-morbid, a pre-existing mental health difficulty, but we do see certain types of mental health difficulties associated with self-harm. So those are things like borderline personality disorder or emotionally unstable personality disorder, or depression, or again, drug and alcohol use. But also it's important to note that not everybody who has those types of difficulties does self-harm. There is a clear association, but as we'll see a bit later on, it's important to try and understand the function of the behavior for the person. Are there any at-risk groups? So are there particular types of groups that seem to engage in self-harming behavior more than others? Or are there particular types of groups of society that we need to try and make sure we support in relation to the risk of self-harm? There seems to be so we'll talk a little bit later on about younger people, so adolescents who might engage in self-harm. But there also seems to be a relationship between a restricted group and self-harm. So if we think of perhaps people who are deprived of their liberty, like prisoners, for example. So people in prisons might engage in self-harm or self-injurious behavior to try and communicate something. Or people in secure environments like psychiatric hospitals, or even people from the LGBTQ community as well. So there does appear to be certain groups in society that are at risk of engaging in self-harm. So in that sense, our efforts are probably geared towards trying to make sure that that's something that we cover in an assessment, because we know that that group might be at risk of self-harm. If we think about what sort of outcomes you might associate with people who self-harm or self-injure, unsurprisingly, that there are a number of physical and psychological harms that result from this. So again, if we think of the relationship between having a mental health difficulty and self-injuring, it can also be the case that maybe the pre-morbid condition, which might be self-harm, could lead to mental health difficulties, or vice versa. It could be that the mental health difficulties lead to self-harm. But more often than not, we kind of associate it with negative outcomes rather than positive ones. Okay, so if we go on to the next slide, we thought we'd spend a bit of time trying to understand the motivation to self-injure or self-harm. So why is it that some people harm themselves? And the answer to that question is a pretty complicated one. And it's not the same for everybody. So the best way to try and understand this is always through assessing somebody's needs and trying to understand the function of the behavior for them. But certainly what Andreas and I have found over the years, and if you look at the literature, these are some of the things that people have said in terms of what motivates them to self-harm. So some people say that self-harm is actually a communication tool. They may not have the skills or the ability to express the way they feel with words. So harming oneself or self-injuring becomes a way to communicate something, and that's usually distress. So oftentimes you might find somebody self-harming because they feel a particular way. They feel angry or anxious or irritable. So in that sense, it might also be what we call a maladaptive way of trying to cope with a negative emotion or a negative feeling. So it's kind of a maladaptive self-soothing strategy, and we'll talk a little bit about that a bit later on. People might be trying to cope with life experiences or the way that they feel. And we know, again, from the literature that people who've had what we call adverse childhood experiences may be at greater risk of self-harming because they're trying to manage the way that they feel. And if they don't have support, or if they don't have a network of people around them to talk about the way that they're feeling, this is something that's very accessible to them. They can do it privately. And unfortunately, it's maladaptive, but it might be an immediate way of trying to displace a feeling or displace an angry thought. For some people, it might be a way to tolerate distress, or trying to find a way to tolerate distress. So oftentimes we might see that people who have mental health difficulties really find it difficult to tolerate any type of distress. And self-harm becomes a really important way of displacing that. So if you can imagine what it's like for somebody with, a diagnosis of emotionally unstable personality disorder, any sort of emotional difficulty is really hard for them to tolerate, and they need to find a way to try and displace that feeling. And one maladaptive way of doing that might be to self-harm. And as we've seen through the literature, sometimes young people might have emotional experiences like being bullied, for example. And again, they may not have a peer network around them, or they may not feel comfortable talking about their difficulties with their parents. So they might try and displace that feeling by self-harming. And we'll talk a little bit about a particular therapeutic approach called DBT, which is dialectical behavior therapy, a bit later on. But one of the sort of core concepts of DBT is that sometimes people lack this thing called interpersonal effectiveness, which is essentially a skill that helps us manage relationships, balance priorities versus demands, and allows us to have a sense of mastery over the way that we feel. So if people don't have that, they can't tolerate certain distressing events, they can't cope with stress, and they don't have the skills or their inner resources to manage those feelings when they occur. So again, they may choose to self-harm because it's a maladaptive way and a very accessible way of trying to manage distress. And then probably less frequently, some people describe self-injuring almost like a compulsion. So some people might describe self-injuring for the reinforcing effects of feeling pain. And sometimes we hear from people that, tattooing, for example, might be something they're engaging because they like the pain. Or certainly I've seen people over the years that describe a needle fixation. So maybe they've been injecting drugs, but they like the feeling of piercing the skin and become fixated on the process of injecting because they find some value and some benefit in experiencing that sensation.
Adam, we have a comment, and I don't know whether you want to sort of mention it, from Joe saying self-harm to communicate is seen in people with learning disabilities I think in learning disabilities, self-injurious behavior can be also quite complex and present and have different. So yes, one situation might be that it is the person with a learning disability trying to communicate distress, but there's other scenarios as well. Don't know whether you wanted to comment a little bit on that.
Yeah. I mean, we probably won't go into that today, but yes, you're quite right, Joe. Thank you for that. So we see self-injurious behavior in people with profound and severe learning disabilities, really quite severe forms of autism, for example, who may not be able to communicate or express the way that they feel through words. So you express your distress by maybe hitting yourself or scratching at your arms or your skin. So the motivation for that population to engage in self-injurious behavior or self-harm is a bit different from people who maybe don't have a learning disability. So at the top there, we said it's sometimes an attempt to tell you something or to express the way that you feel. And in that sense, it's a behavior that your carers or your clinical team would try and support. So we might use things like picture exchange, something called PECS, which allows somebody to express the way that they feel through pictures rather than words. And you might see a reduction in self-injurious behavior that way. Or it might be a sensory sensitivity. So sometimes we see, again, people with autism get really distressed by environments that are overbearing in a sensory manner. And they may try and tolerate sensory overload through self-harming. Or again, it might just be a sensory experience for people with profound and severe learning disabilities or autism. But again, we'd need to try and understand the function of the behavior for that person. So we'd always look at it on a sort of on a case-by-case basis.
And we have another question about whether there's a commonality between these courses. And I think Adam has already sort of spoken to the fact that, that there is this thing about there being emotional distress and then either being a difficulty communicating it or difficulty coping with it in some kind of way. But there's other situations. So I don't know, Adam, what are your thoughts about? Is there a commonality that runs through the whole thing?
Yeah, I think so. I mean, if you look at the commonality across all of those different groups of people, I think, it's a distressing event for people to engage in. So, we talked a little bit about shame and guilt and negative outcomes. So a common outcome of engaging in this behavior is that it's distressing for the person themselves, but also distressing for people around them. So the motivations might be different, subtly different in some ways, but it's associated with distress. And it is something that we would try and support that person to change because it's maladaptive. So it is something that might feel as though it has a positive effect quite immediately, but obviously it's putting the person at risk. And we're describing it there as sort of non-suicidal self-injuries. Sometimes it can result in really serious harms. So maybe the intent's not there to end your life, but it could be so severe as an episode of self-harm or self-injurious behavior that it causes somebody some real risk and really affects their well-being.
There's another question which is interesting. Has it increased during the pandemic? I mean, to my knowledge, we haven't seen an increase in self-injurious behavior during the pandemic so far. I mean, I think it's hard to say because we probably have not collected the data, and some of the papers that we might be seeing later on have not yet been published. So you need a period of observation and then sort of gather data, analyze the data, write the paper, get the paper through peer review for us to see that information. So we haven't seen it so clearly. And I think people were expecting much more of a signal than we've seen so far. But who's not to say that once that process that I've just described is finished, we might see an increase there. And also after the pandemic, quote unquote, resolves or things go back to normal, paradoxically, we might also see an increase because there might be consequences of the pandemic that carry distress with them. the economic outcomes, the economic fallout of the pandemic is not clearly seen, and we know that economic deprivation is linked to distress and self-harm. So I'm not sure we know yet. I don't know, Adam, if you have any other thoughts.
Yeah, I think you're right. I don't think we know. I think the concerning thing is that people's ability to access services has probably been compromised during this period.
That's definitely true. Yeah.
Some services are closed, or they're offering remote support, so less intensive support sometimes. So again, if you think about what works for this population, it's about provision of adaptive coping skills. So if that gets taken away, some people might find themselves engaging in what they've done historically that's worked. I mean, we don't know is the simple answer, but I can imagine some people struggling for those reasons.
Yeah, that's a good point, because we might be under recording them because the services are less accessible. We might not see it so much in the stats.
Yeah.
And later on, we will learn that probably there was an increase. We just don't know, to be honest. Yeah.
Yeah. Okay, so I'm on slide 3 now. So yeah, I think we're kind of touching on some of these points anyway, but we thought we'd just have a think about personal factors and their relationship with self-harm or non-suicidal self-injury. So is there a difference between genders? And the answer to that is it kind of depends what paper you're reading or where you're looking. And again, it does seem to be context specific. So, if you look at rates of self-harm in prisons amongst male prisoners, it's really quite high. If you look at rates of self-harm in community samples amongst some services, it's higher for women. So it really depends on the context and the type of difficulty that people present with. But both males and females do engage in self-injurious behavior. Are there differences with age? Again, it depends on where you're looking for evidence to try and substantiate this. I mean, there's some studies that look at general population of adults and their rate of non-suicidal self-injury ranging between 1% to 4%. And then it seems a bit higher for community samples of high school aged adolescents, around 8 to 16%. But again, it seems to be context specific. And then if we add on all these additional variables of having a mental health problem, feeling isolated, having a lack of a peer network or family support to be able to protect against these sorts of things, then it tends to increase a little bit. But we'll touch on this a little bit more. There is a relationship between having a mental health problem and engaging in self-harm, and the direction of the relationship is not always that clear. So I mentioned previously that if you have a diagnosis of borderline personality disorder, emotionally unstable personality disorder, that may put you at risk of self-injuring. But it's also the case that if the self-injury or self-harm comes first, it can lead to mental health difficulties like shame or guilt or anxiety or depression. So it's important to try and understand the function of the behavior for that person. As you'd expect, you see quite high prevalence rates amongst younger people, particularly teens, in inpatient settings. So, and that might be a common sense statement to make, and maybe that's why that person is in hospital under care, but also you do see quite high rates. So if you're working in a CAMS unit, an inpatient CAMS unit, you might see that more frequently than in other settings. And then again, there are other sorts of difficulties that we do associate with self-harm, depersonalization disorder, dissociative disorders. But for us, it's important to look beyond simple labels because it doesn't help us understand the person or the function of the behavior, and therefore how you're able to make changes in relation to how they manage things like distress. And then, we've sort of mentioned marginalized groups who are at risk. So we mentioned members of the LGBTQ community, refugee populations, people who are seeking asylum, and obviously prisoners. Okay, so we'll try and go a bit quicker so we've got enough time for the vignettes. But we thought, having sort of introduced the topic and talked about some of the harms and some of the outcomes that might be associated with self-harm, it would be interesting to think about how you might support somebody to make a change. And these are some of the talking therapy options that are available for people. And these are what we call NICE recommended interventions. So first off, in order to keep the person safe, you might support them with what we call harm reduction strategies. So this is kind of the first step, really, to make sure that the behavior is reduced so that it doesn't cause them any severe harm. So sometimes you might ask somebody to wear an elastic band and flick it every time that you have an intrusive thought or a thought around self-harming. So instead of actually physically harming through cutting, you might have something similar by way of a response by flicking a band. In that sense, it's a harm reduction strategy. Other people have said that they use ice cubes to try and mimic the same sort of sensation rather than cutting. Or other people find that if they exhaust themselves through high intensity exercise, then that reduces the risk of engaging in a self-harming behavior like cutting. So that doesn't work for everybody, but it might be just a strategy to employ very early on so that it reduces the risk that that person might present with. And then when you have some sort of stability, you might be able to support them to engage in a therapeutic relationship where you offer some form of psychological therapy. And this is really where you can take the time to understand the function of the behavior for the person, and you can begin to address some of the difficulties that they may be experiencing. So we've listed a few psychological interventions there. So you'll all be aware of CBT, and that might just be really about trying to understand and recognize negative thought processes and replacing them with more adaptive ones. So again, there, what you might be trying to do is to support somebody to think differently about the event and replace the self-harming with something that's a bit more adaptive. So something like a coping strategy, for example. Then this form of therapeutic intervention called DBT, which is dialectical behavior therapy. This is recommended for emotionally unstable personality disorder, an example, and sometimes that could become the sort of overall treatment model of an inpatient unit, for example. So this is a really lengthy therapy and it's skills-based. So what that will teach you is the ability to manage distress, the ability to cope with upsetting life events, and it will support you to develop this thing called interpersonal effectiveness. And it will also help with reducing the thought or the urge to self-harm. So a lot of this work will be about trying to keep the person from engaging in self-harm and replacing it with more adaptive strategies. And then there's other types of interventions, particularly for young people, that might involve a network, so their family, and that really places the person at the heart of the intervention, but looks at mobilizing the support around them, because that's obviously something that's really important for younger people in particular. So those are just some of the interventions that are on offer. But this isn't a blanket approach. It's really about trying to understand what works for the person that you're seeing.
Yeah, and I think it's important to understand that it is treatable and people do improve. And again, Adam and I have had very chronic cases that we've looked after, and we've seen improvements and we've seen reduction in these behaviors, and we've seen people even in hospital after being quite ill, those descriptions that you've heard, being able to sort of then go on to be in the community, be safe, and carry on with their lives. So you might, again, it's a little bit about that idea that we had at the beginning, or that we commented on at the beginning, about the stigma around this. I think the whole stigma around it might make it worse in many ways, but B, people do recover from these things, particularly if you intervene early. So I think Adam wanted me to comment on two quick things, which is that the use of medication. Is medication useful at all? So you've seen those psychological strategies. DBT in particular is probably the one that is most frequently used for good reason, because that those interpersonal skills and the ability to identify emotions and the ability to self-soothe are core components of it, and they are at the heart of self-harm, or many cases of self-harm, I should say. But is medication useful at all? And the answer is no, not really. So we have not. NICE, again, the National Institute for Clinical Excellence, does not recommend the use of medication specifically for self-harm at all. And even though there were studies published for some medications as a strategy to decrease self-harm, there's no real, none of the trials that I've seen or that anybody has seen has shown that it's helpful. However, as you've heard, in many cases, self-harm may be associated with an underlying condition. So, whereas some cases of self-harm, there might not be an immediately identifiable mental health disorder, or the mental health disorder that is identified is not very well amenable to treatment with medication. Some are, we see self-harm in depression, and we can treat depression. We see self-harm sometimes in psychosis and in other scenarios where there is medication that can be used. And in those cases, what you're doing is you're not treating the self-harm directly. What you're doing is you're alleviating the underlying condition by using the right medication. Again, it's important to understand that you're not going to do these things on their own, and they're less useful on their own overall. And that you also need to sort of think about the other components of the treatment, as Adam was saying. So this is when you're dealing with self-harm, sometimes you do resolve it because the underlying condition may be the sole cause of the distress and the sole cause of the self-harming behavior. Although that tends to be rare, and you tend to need other strategies to go along with prescribing any medication for an individual. I think what we wanted to give you is a little bit of a flavor of what a case of self-harm, self-injurious behavior might look like. This is a real case, a real clinical case. I chose somebody young so that you could see what the onset of these things may look like as well. So, you'll see in this case how it's going to resolve. But we see adults that start kind of like this often. So we've got a 15-year-old girl here, and she started cutting age 13 because she learned the behavior from her peers, which is interesting. This is, again, more common a story than you might think. So after she tried it once or twice, she felt that she was hooked, and maybe there was some of that relief, some of the things that Adam was mentioning earlier about the physical sensation of the pain helping with the emotional distress, and then that in itself being rewarding. So she cut herself on her forearms. Then probably that was noticed, that she switched to upper thighs because she didn't want people to sort of notice or tell her off because of doing it. And the primary reason, and again, you hear this quite frequently, is to release this built-up emotional pressure. So she gets this emotional pressure. She doesn't know quite how to deal with it, and the maladaptive strategy that she's developed is to self-harm, and that eases that pressure off. So you know that there's a link between having an emotional conflict with either her parents or maybe a perceived rejection, and this perceived word is quite key here. So perceived rejection by a peer, and that leads to self-harm. That leads to those overwhelming emotions for her, and she needs to release them somehow, and she self-harms to do that because they become too much for her to cope with. Now the frequency comes and goes, and it went, before she presented or as she came to services, it went from daily to monthly. That's how she was presenting. So when she was assessed, we discovered she had depression, more or less from age 14 or so, 13. So there's some description of the symptoms. And when she presents, she meets criteria for moderate to severe depression. So there we go. So we've got a diagnosis, we've got a formulation. How are we going to sort of deal with this case? Well, she was offered counseling, which she rejected. She actually did try. But she felt that she couldn't get on with the therapist, that the therapist didn't get her, that they didn't click, I think is how she put it. And then she was treated with an antidepressant called fluoxetine, and that improved her mood to the point that all her symptoms, her mood symptoms, the depression, if you will, resolved. So it kind of improved and it went away. Now, the interesting thing is that even though the depression had been resolved by all accounts, her self-injurious behavior, the self-harm persisted, and she was engaging in it about twice per month. And again, the characteristics were very similar, interpersonal, some kind of perceived interpersonal conflict or some kind of situation at home would become overwhelming. She would self-harm as a result. So relevant to the case, just so you know, in this young lady's case, mother had a history of recurrent depression. Never needed hospitalization or anything like that, but she could be off work and that sort of thing, and he tended to come and go. And the father had a fairly long history of alcohol dependence, but at the time she first came to services, he'd been sober for 3 years. So when looking at her life history or what happened to her when she was younger, there was a lot of shouting at home, conflict between the parents. There's sometimes physical altercations between the parents, and some perhaps quite rough disciplining of the children at times. But none of the events ever amounted to abuse or neglect, or I mean, the history was not clear of abuse or neglect. The parents divorced, and Veronica and the two siblings had an older brother and a younger sister, were in joint custody between the parents, and there were a poor relationship between the siblings, older brother and younger sister. Veronica in particular did not get on with them. Felt that the brother was cruel and overbearing, and younger sister was too naggy or something like that is how she put it. She was an okay student, and she had a good peer group, moderately sized, with recent friendships. She was in high school or whatever it's called, not sixth form, I think before that, doing her GCSEs, yeah. So when it was all resolved, when she presents, she has no current suicidal ideations, no symptoms of depression, but she had this presentation. She had this difficulty expressing emotions and even identifying her own emotions. She had this egocentrism. She had this hostility towards others, very easily hostile towards others, and this interpersonal sensitivity. She would tend to interpret things as being directed at her from her peers, and be very ready for conflict, and perceive slights from just about anybody. She had poor ability to regulate her own emotions, so they become, they fluctuate widely, and they can become quite overwhelming for her. And she didn't have a full awareness of this processes or what was going on with her, and she didn't have any way to regulate her emotions except for using self-harm, as we saw at the beginning. So how was she treated? She received no medication at all. I mean, she had already been treated for depression. She'd recovered. She hadn't relapsed, and the antidepressants had been stopped, so there was no need to continue with those. And she was offered, and because there were no symptoms there was no underlying condition, as we saw earlier, so there's no reason to use it. So DBT, which is what Adam was talking earlier, was what was used. And these are the outcomes that she experienced. So self-harm reduced initially and then stopped after 2 months. So again, it's a long process. So it's not like, it's 2 months of treatment in this particular case, and better able to identify emotions, develop some strategies in self-soothing, improved her interpersonal relationships, and her ability to maintain interpersonal relationships, was better at perspective taking, not taking offense so quickly at things, and less sensitivity and hostility. So those were the major changes, even though the situation at home was still difficult, and all the chaos remained there. So this was purely through her developing of these skills. And I suppose my point here is that this is, so if we hadn't been able to intervene in this particular case, and actually this is becoming less and less possible. So these days, and Adam will correct me if he has a different perspective, but these days you need to be seriously unwell for services to notice that, or to offer you a service. So I mean, if you saw the history of this particular case, she didn't have severe self-harm, or certainly nowhere near life-threatening self-harm. She was picked up for treatment. This was part of her case was part of a clinical trial for DBT. So she was invited into this treatment. Now, I think she wouldn't have had, if the trial was not open, I don't think she would have been offered treatment by the local CMHT. And this is what happens. We then see that all of these skills that she hasn't developed, they compound the problem for individuals like this. So because she's not good at interpersonal relationships, because she's hostile and sensitive, then the quality of the relationships that she tends to form is poor. And as she gets older, perhaps she may sort of develop a relationship with somebody who might be quite abusive. She's not so good at protecting herself, or the relationships that she's able to form are unstable in themselves. They may in themselves compound the problem. She's not learning any strategies to cope. So the self-harm in itself becomes reinforced. And you have a situation which becomes much more chronic. And in this case, we saw that she didn't quite meet criteria for anything, but Adam was talking about the development of emotional and unstable personality disorder. So if not handled at this stage, if not taught these skills, if not made able to understand and regulate her emotions better and self-soothe better, she may have gone on to develop something like an emotionally unstable personality disorder, which then is much more chronic, much harder to treat, and might lead to much more dangerous self-harm in the future, and leading to much poorer outcomes. That's kind of what I wanted to show you as a case study, just to get a picture of what this might look like in reality. But then, yeah, so basically what we would like to do now is to open it up for any more questions that people may have about this topic. So yeah, so if you want to submit your questions, that would be great. I don't know if, Adam, while we wait for questions, you had any comments on the case.
Yeah, no, I mean, I think you're right. It's really about, trying to reduce the barriers to get support when people seek it. And I think, unfortunately, sometimes, depending on the context in which somebody seeks help, something like self-harm can just be seen as attention seeking, and a phase that somebody might go through, and they might not get access to the support that they need for those reasons. So I think that the understanding of this as a difficulty in its own right has improved dramatically across primary care settings and A&E, and other services people may seek to get support with. But yeah, it is something that needs to be done compassionately and sensitively for obvious reasons. So yeah, I think it's often the case that people find it difficult to seek support anyway. And if it's something that you might feel has a lot of shame and guilt surrounding it, it might be even more difficult. So thankfully, I think services are really good at understanding that it's difficult for people to seek support, and it's difficult for them to sort of acknowledge that they might be self-harming. So it does find its way into assessments these days. I can see we've got quite a few questions that have come in.
Yeah, good. So we've got here a question from Evelyn. She's asking, is there any research on what causes people not to develop interpersonal skills? And she then asks, could school do more to teach this sort of skill? Do you want to tackle that, Adam?
Yeah, I mean, I think the case vignette probably did a really good job of illustrating the importance of getting in early. So, you know, a lot of services look at this thing called early intervention. So you try and intervene at the earliest stage possible so that it gets managed without it, you know, resulting in a more difficult to treat problem in adulthood. I guess there's a couple of things competing with that. So there are lots of good examples of services that are offered to younger people to prevent them from developing difficulties that continue into adulthood. But there are challenges to that. So, you know, social media and the internet generally give a really difficult challenge to services because they influence the way that people think and feel. So I'm sure a lot of you have seen this in the media. I can't remember exactly when it was, but there was a bit of a trend that was circulating on social media around self-harm, and it then sort of spread around, and people were self-harming to sort of, you know, be part of that group or whatever it was. So there are really good initiatives to try and support people who need it at school level, and, you know, teachers and other professionals in schools are trained in safeguarding and other approaches that they can spot when things aren't going well for young people. So it's improved dramatically, I think, certainly in my time in mental health.
Yeah, I mean, in terms of research of what causes people not to develop these interpersonal skills, we tend to see, similar to the case that we described at the vignette, is, you know, we tend to see situations in where there's a lot of conflict between maybe the parents, and there's like, you know, shouting and screaming, and there's no good regulation of emotion on the part of the parents, and there's no good dealing with emotions on the part of the parents. This is something that we can see commonly. In this case, there wasn't any clear abuse, but there was certainly, you know, what you might consider abuse between the parents that the children were looking at. And so when emotions became difficult, it resulted in some, you know, in a physical altercation or in a shouting match or something like this. So those kind of environments can lead to a deprived environment, or an environment where there's a lot of conflict or distress, can lead to presenting with this with the inability, or not the inability, but the lack of opportunity to develop these skills, or the lack of nurturing to be able to develop these skills. I think that's what we tend to see. I don't know, Adam, if you have any other thoughts about that.
Yeah, no, I agree.
We have a question here about somebody who has a daughter, niece, that is going through self-harm. How could they get their niece DBT at the moment? You're more up to date with that than I am, I think, Adam.
Yeah, I mean,
what is the best route?
I think at this stage it's just about, if we answer that question in terms of how do I get support for somebody?
Yes.
And I think, you know, the best way always is to speak to your GP. So if you're concerned about something that relates to some of the things that we've talked about today, please do go and see your GP. They'll be the best people to signpost you to other services like CAMS, or maybe an IAP service, which will offer talking therapy. But the important thing there is to get an assessment, so that somebody like a GP or a mental health professional can try and understand what's going on for that person, and then signpost them to the most appropriate service. So GP initially, and they'll then be able to make a referral on to the appropriate service, if that's a CAMS service or a community mental health team or an IAP service.
Yeah, so CAMS, just so people know, is a child and adolescent mental health service. Sometimes people are able to refer themselves directly, not very often. Very often it is through the GP that you find your way into those kind of services. And IAP, this increased access to psychological therapy, is again it's talking therapies. It could be face to face, but it could also be online, depending on what is offered in your particular area. But again, the person to go to first is probably the GP to guide you through those local services, because they vary from place to place. Do you have any suggestions on how to deal with someone who's self-harming in front of you? So people who might be, for example, hitting themselves. What should people do to help somebody who's self-harming in the moment? What do you think, Adam?
Yeah, that's a really difficult one to answer. And I think that, you know, the important thing to say there, it's really distressing. It's a really distressing event to have to witness and be a part of, but it's also really distressing for the person that's doing that. And again, I mean, there are no sort of blanket approaches, as in when this happens, do this. You have to try and understand the function of the behavior for that person. So, you know, some of the things that Andreas and I have seen with the other teams that we've worked in across the years are sometimes that you might just let somebody engage in the self-harm, and you might give them sterile equipment to help clean themselves afterwards, rather than try and, you know, intervene or restrain or to stop them from doing it. Or other times we might see sort of what we call low arousal approaches, which is almost like a de-escalation technique to try and help somebody calm, and then maybe take some time to just extinguish that thought or feeling, because obviously it's one that's associated with a really elevated state of arousal. So you might just try and support the person to calm themselves, and then maybe the urge to harm themselves extinguishes itself for that moment. So a mixture of things, but it is really difficult when you're in the moment and you're trying to support somebody. You know, low arousal approaches don't necessarily think about things like restraint, and that's obviously the last strategy that's available to you. So a lot of services are sort of geared towards not doing that at all. So everything needs to be, you know, the least intrusive, most effective intervention.
Yeah, so I mean, if you're out, if this is a family member or somebody or a member of the public, then you might want to see if you can, if you have the inclination. You don't have to do anything, but if you do have the inclination, you may want to see if you, just by being calm and talking calmly at them and say, well, why are you worried? What's distressing you? What is the problem? Just try to engage them in conversation. That low arousal may work, so may help, you know, discuss what it is that is troubling them, and might sort of reduce the urge to self-harm in the moment. Then you have to decide about how serious it was, and you may want to, if you don't feel confident to approach them or anything like that, but you feel that but you're worried about the harm that they're doing to themselves, you might consider calling even an ambulance if it's severe enough, given that, you know, depending on the circumstances. So I don't think you would want to sort of you would never want to sort of stop them physically or restrain them in any way, or take away whatever it is that they're using to self-harm. That might be quite difficult to do out in the community. I mean, I don't know what scenario you have in mind, but, you know, that's probably not a thing that you want to do, because they might be quite distressed, and you know, it might lead to more conflict rather than less. So yeah, low arousal, try and speak calmly to them, understand why it is that they're doing this at this point in time. Maybe they can explain it to you, and just by explaining it, then maybe they'll be able to sort of self-soothe and calm down a little bit just by speaking about it, and then decide what level of urgency this presents, and whether you want to encourage them to to get an appointment soon with somebody, or even, if you're worried about this person, and you may call an ambulance yourself, and the paramedics will know how to handle somebody who's actively self-harming. They've been trained to do that. So yeah, I hope that helps. But it's a difficult question to answer because we don't understand exactly what scenario you have in mind. There's a comment from Debbie. She's saying, I think there's a lack of understanding at the young age depression, anxiety, and other, maybe a lack of understanding at the young age depression, anxiety, and other issues can present. I think there needs to be more support for parents who might not see signs early. Yes, absolutely. And, we try to do this. We have a collaboration with Brothers in Arms, for example, which aims to make we have a therapy service that we offer through the app, and our therapists are there to support parents who might have questions about their teenagers or might have this kind of concerns. So the parents are able to sort of talk to our therapists and maybe get an understanding of how they might do, or what are the signs, what they could and couldn't gleaned from the behavior of the teenagers, and what the best approach might be in this specific case. We don't offer support to teenagers directly. We can, the service is not configured to do that, but we can support parents, and we do so. So there we are. Let's see. Are there services available to minors to reach out in the event that there is abuse at home, where the GP doesn't take them seriously? The GP doesn't take them seriously. I mean, safeguarding children is such a big issue that, yeah, I suppose it's possible that the GP will not take it seriously, but I don't know. What do you think? What do you think, Adam?
I think if you're concerned that your concerns aren't being taken seriously enough by that person, maybe try and speak to another GP at the practice. In terms of, I mean, it depends what the issue is. I think that, I mean, there are services,
Childline,
Childline, that are available, but yeah, I'd maybe try and speak to another GP at the practice if you feel they're not taking your point seriously enough.
Well, mainly the main port of call for minors who themselves are worried and they don't know who to speak to is Childline, so that you might be aware of. So yeah, they do a good job of supporting minors who might be victims of abuse. I mean, safeguarding children is such an important topic in healthcare these days that, of course, try and get help from somebody else that in the practice, but, most GPs will take this very, very seriously, I should say. Yeah. I think we're run out of time, so there's quite a few more questions. So thank you all very much for all the questions that you've posed. We hope that was useful. Yeah, thank you very much for your attention. Adam, any parting words?
Yeah, no, just thank you for your participation. If you do have some more questions, you're concerned about something, please go speak to your GP.
Yeah, thank you. Thank you all very much. Bye.